So the next topic will be diabetes in older adults. The speaker will be Dr. Supratik Bhattacharya, who is a well-known endocrinologist and director of SKN Diabetes and Endocrine Center. And the chairperson will be Dr. Orkojit Ghosh, who is a consultant diabetologist and obesity specialist, and Dr. Mridul Bera, who is a specialist in internal medicine and associated with Narayana Hospital.
So the next topic is diabetes in the older adults and areas of concerns. And for this, we have that eminent endocrinologist, my favorite, one of my favorites, Dr. Supratik Bhattacharya. I'll invite Dr. Supratik Bhattacharya to speak on this aspect, diabetes in the older adults. Definitely, there is a lot of areas of concern, and I will give 20 minutes to talk about this. Over to you.
Thank you, Chairperson, and a warm welcome to all of you who has joined today. So a big thank you to Dr. Mridul Bera, Dr. Sanjay Shah, Dr. Guru Prasad Bhattacharya, and the entire team of HDS Con. And I think it's a fabulous topic to have on board because we are dealing with a lot of elderly individuals on regular basis. And so today's talk is very pertinent to what we practice on a daily basis. So diabetes and elderly areas of concern is my talk today. And we know that from the various landmark trials like UKPDS, VADT, ACCORD, that the duration of uncontrolled glycemia is related to microvascular complications. And also from a very recent trial done by Dr. Kamlesh Kunti and group from UK showed that if you fail to reach the target A1C within the very first year after diagnosis, you significantly increase the chance of a cardiovascular event at the end of 5 years. So it's not only the microvascular complications that we are talking about, but we are also concerned about the macrovascular complications as well. And the clock for macrovascular complications start ticking even before the diagnosis of diabetes. And very recently, you'd have seen the 24-year follow-up study of UKPDS, and it shows that if you had a good glycemic legacy, that would also reduce the burden of myocardial infarction and death overall. So prevalence in elderly, it's over 25% of individuals aged more than 65 have got diabetes. And the prevalence increases with age due to factors such as sedentary lifestyle and genetic predisposition. So aging is something which is inevitable, and that takes a toll on various organs of the body, including the pancreas. And there's a reduced pancreatic function and also insulin sensitivity. And Indians, because of the increased visceral fat and insulin resistance, we know that we are naturally predisposed to declining insulin levels as well. So lifestyle, poor diet, lack of exercise, obesity, and obviously we have the genetic factors that are already there. So a very strong family history, for example, would increase the risk. So what are the complications? We said there is an increase in the micro as well as macrovascular complications related to diabetes. Like cardiovascular diseases are more. Obviously, we had been talking about the kidney diseases as well. So diabetic kidney disease as well as CKD is more prevalent. And also some concern is, well, I'll say a major concern is the visual problem. So, like anybody who is on insulin, I think it's a major challenge. As you grow old, you need to find more convenient ways, because somebody on a basal bolus therapy, for example, who is having to switch between the various pens, it might be difficult for a person who has got low visibility. So I think the future is that we are coming with more flexibility. For example, Icodec, for example, is one of the insulin which can be given once weekly, and we're waiting for that. Similarly, we have once weekly GLP-1 receptor analogs, which are sort of, helping us in managing diabetes in the elderly individuals. Impact on daily life, mobility issues. This is a big thing. We are generally concerned about the falls in elderly individual, and a single fall can increase the hospitalization. Difficulty managing blood glucose and medications. Very frequently we see that somebody with diabetes has got an entire list of medications, not only to treat diabetes, but also the comorbidities like blood pressure issues, cholesterol issues, and very frequently we see that with the declining cognition, they forget to take medications. And somebody living with diabetes for many number of years, sometimes they become very frustrated taking medications day in, day out. So that's again a big concern. Depression is not uncommon in those who are elderly individuals. Social and emotional impact due to dependency on the caregivers. Many of my patients, they're immediate families living abroad. And now we are falling back on more robust healthcare support system. And they are usually visiting us with the healthcare workers who are actively involved in their care. Glycemic control challenges. Older adults often have more fluctuating blood glucose levels, and coexisting health conditions can complicate treatment issues. And you have to be very judicious while trying to not over-treat the person while treating them. So be very, very careful, because we know there are many issues related to dyselectrolytemia, for example, in elderly individuals. We also want to ensure that you're not over-treating them, which would cause them harm. Hypoglycemia risk. Again, this is another big concern, because a single episode of hypoglycemia is going to be detrimental, because they might not be asking for help in the right time. More importantly, hypoglycemia can cause a fall and increased risk of fracture as well. So symptoms may be less obvious or mistaken for other health issues. What about the hyperglycemia risk? Again, high blood sugar can lead to long-term complications such as nerve damage and cardiovascular issues, and delayed detection in elderly individuals can worsen the outcome. So this was a slide that I took from Dr. Valentin. He is the man of technology, and he's the man behind ATTT, who showed that if you're using CGM or flash CGM more often in the elderly individuals, we can actually not only get a better glycemic control, but also we can improve the outcomes in terms of reducing hospitalizations, as well as preventing other complications that arise out of diabetes. So I think we need to be very proactive in using these devices in the elderly individuals, because they have to understand the glycemic pattern as well. And it's always useful for the doctor to understand what is the glycemic variability in an individual, especially those who are elderly. Neuropathy concerns. Diabetic neuropathy can cause numbness, tingling, pain, and this is something that we talk about during the history taking, and we actively ask for this. And this increases the risk of falls and injuries. Is that mine? It's not mine. Okay. So this increases the risk of falls and injuries in elderly patients. So the feedback is not as good. Retinopathy, again, something that we screen on a regular basis for anyone living with diabetes more than 5 years, for example. So diabetic retinopathy can affect the vision, and regular eye examination, including looking at the fundus, is absolutely essential in these elderly individuals. Nephropathy, again, declining eGFR is very commonly seen in the elderly individuals, and we now have an armamentarium of drugs that we can use to prevent end-stage renal disease, and we need to bring them in at an early stage rather than missing the bus. Cardiovascular risk, again, we now have robust guidelines in place mentioning the kind of medications that are useful in a background of atherosclerotic cardiovascular disease, the background of heart failure, for example, and we need to have them in place, because having diabetes by itself makes the person in stage A heart failure, and they would actually qualify for many of the agents that are listed in the guidelines under the heart failure category. And obviously, we need to be proactive in treating the patients with the right kind of agents to ensure that we're preventing a cardiovascular event. Managing cholesterol issues with proper statinization, and also not only initiating them on statins, but up titration of the statins to achieve the lipid goals is vital in these individuals. Cognitive decline, again, something that we very commonly come across in the elderly individuals, and we know that the risk of dementia and Alzheimer's disease is very common in those living with diabetes for many number of years, and we have to actively screen for those. If required, you can do a mini-mental score examination and take help of your team. So obviously, if you are treating diabetes, it's not good enough to be the only consultant. You have to have a robust team in place, and that would include psychologists, for example. You require a whole gamut of assistance that comes with the care of these individuals. So blood sugar control may help delay cognitive decline, but obviously, as you say, age by itself is a predisposing factor for cognitive decline overall. Depression and mental health. Elderly diabetics are more prone to depression due to the burden of managing disease. Regular mental health support is important for overall well-being. Maybe you can introduce them to the support groups that are available and signpost them so that they can talk to each other and help manage their condition. Food care issues, again, we have podiatrists in place, vascular nurses as a part of the team. They regularly, screen for diabetic foot ulcers, which is a major concern. Many times, because of the lessened flexibility, they can't look at the bottom of the feet, so they can use mirrors, and you should show them how to actively look for any cuts or blisters at the bottom of the feet and use proper footwear, and regular checkups can prevent serious complications and even amputations. Nutrition concerns. Again, we are aware of sarcopenia, and we say besides the aerobic exercises, there has to be 2 days assigned in a week for resistance exercises to prevent muscle loss. And in elderly diabetics, we should also talk about the nutrition. We know that in India, very frequently, we don't have high quality protein in our diet. Our diet mostly represents, if you look at the plate, 60 to 70% is carbohydrate, and the representation of good quality protein is very less. So we have to emphasize that, and nutritionists obviously sit and counsel the patient regarding the need for this quality nutrition. Also, micro and macronutrient deficiencies are something that we come across very often, and we need to supplement that on a regular basis. Polypharmacy, again, we see an entire gamut of medications on the list, and as we said, with the declining cognition, sometimes they forget to take the medications, and it's really challenging to cope up and manage their condition well with that cognitive decline. Drug interactions can complicate diabetes treatment overall. And we already talked about the insulin. If you have low visibility, obviously that becomes a concern to look at the fine prints, and you would require assistance for someone who has been using insulin for many number of years, or have to switch between the pens. So keep it very simple when it comes to elderly care. Try and advise them something which fits in well into their schedule, minimize the number of medications, and also screen for those kind of medications that can cause hypoglycemia, dyselectrolytemia, etc., and try and put them on safer medications. Monitoring and adjusting doses can be challenging due to age-related factors. Physical activity, regular exercise is crucial. As we said, some form of resistant exercise to ensure that the person is not undergoing sarcopenia and maintaining their muscle mass. And physical limitations may require tailored exercise plans. Blood sugar monitoring, we said, home monitoring of blood sugar with glucometer, and also something like a flash CGM, which is very, very helpful. And now you have the app on your phone and you can see it on real time with the Libre Pro sensors. And this is very, very important. And they come with alarms as well, the new generation ones, which can sort of warn you regarding the impending hypoglycemia. Simplifying devices and providing education obviously helps. The role of caregivers is a big, challenging role for the caregiver because they are the immediate support system. So you need to sit and counsel them that managing elderly patient with diabetes is a challenging thing. It's a long-term, involvement, and you need to be actively involved in the management of the individual. So support and caregivers is essential to ensure proper care. And health literacy, obviously many elderly patients may lack the knowledge to manage diabetes effectively, so you can signpost them to good quality materials. Now many of them are tech savvy, they will scroll through YouTube channels or come across various informations that they're on the social website, so you can signpost them to those places. So importance of regular health checkup, as we said, make sure that they're meeting their doctors very often at a regular basis, and also they're being screened for health issues like heart diseases, kidney function, eye, etc. You should be getting on board and using technology more often for them, because we know that using technology and adapting technology to manage diabetes in elderly is going to improve the outcomes, as we had shown you before. Coming up with policies. So this is something that happens at a higher level, and we need to actively intervene and ensure that healthcare system provides better support for the elderly diabetics, including accessible medications and education programs. Policies should focus on preventive care to reduce the long-term burden of diabetes. Preventive measures, we already talked about: proper diet, exercise, regular monitoring, vaccinations in elderly individuals, adult vaccinations, we are talking more often about it now. And community support programs also goes a long way. So this also is a support system. So in conclusion, I want to say that effective management of diabetes in elderly requires a multifaceted approach. By addressing the challenges and utilizing the available resources, we can improve the quality of life for the elderly individuals who are living with diabetes. Thank you.
Hello. Whenever I hear Dr. Supratik speak, I never say that it was a wonderful speech, but I'll say that it was a bliss. I just have two questions from my side, setting the ball rolling. Number one is diabetic obese elderlies or the frail elderlies. We cannot have strict diet regimes for them. So what should we plan for the weight loss of those patients? And especially if the patient has CLD. And secondly, I think a lot of people will ask here, the specific HbA1c targets. I mean, we can, whether we should go for a strict one or we can relax a bit, even be happy with 7.5 to 8 sort of a thing. Yeah.
Yeah, so I'll start with your second question. So HbA1c target is like your shoe size. So one shoe doesn't fit all. It has to be individualized, customized, based on the number of years of diabetes, the number of comorbidities that we have. So a lot of things come into play when we are deciding the right A1C for the individual. Obviously, for an elderly individual living with diabetes for many number of years with comorbidities, we are not going to target an A1C of 6 or 6.5. So we are happy with 7, 7.5. Even 8 at times is acceptable, depending on the situation, And now your second question is how to deal with obesity in elderly patients. So we do have agents like GLP-1 receptor analogs, which are known to cause a robust amount of weight loss. Unfortunately, those who are not having diabetes, managing weight is an issue here in India because we don't have dedicated weight loss molecules available with us. Like, for example, liraglutide 3 mg Saxenda never came to India. So Wegovy is a long wait for us. So dedicated, so
Glycemia, I think you are participating in the trial, even I am also part.
yeah, so we are a bit limited in that space, but in that scenario, type 2 diabetic individuals who are overweight or obese, we do have a lot of things that we can take on board, especially the available GLP-1 receptor analogs, whether the once weekly ones, once daily injectable ones, or even the oral GLP-1 receptor analog that we have. And we had published our first data on oral semaglutide. It was a multicentric study, and it did show a very robust drop in the body weight, which matches the pioneer studies that were seen from the RCTs.
Any question from the audience?
Very nice talk. Only issue is, we come across quite often elderly, female, frail diabetic patients. Now, what should be the, it has to be individualized, as you clearly said. Now, what are the drugs to be avoided? For example, we know these patients are often having CKD, maybe having some CVD and all kinds of comorbidities. But SGLT2 inhibitor, we have to be very, very careful, in these frail patients. Elderly lady, I'm very specifically saying. So how do you approach these kind of patients with whatever medications we have?
So you'd be surprised how safe SGLT2 inhibitors can be even in frail elderly individuals if we are screening for the right kind of patients and initiating the right patients on SGLT2 inhibitors. So we just need to be vigilant. We need to take a robust history and monitor them while we started them on SGLT2 inhibitors. Overall, being elderly, being frail is not a contraindication for SGLT2 inhibitors. But we have to be watchful with some other agents. For example, sulfonylureas at higher doses is something that we need to be watchful about. We need to be watchful about dyselectrolytemia. So the associated comorbidities, if you're having any antihypertensive, for example, which can cause dyselectrolytemia, you need to be watchful regarding that. And obviously, even the injectable agents that are also to be used with caution, and you need to regularly monitor them.
The Supratik, so the lot of the elderly patients may have these opposite type of characteristics. One is the frail one, and another is the obese one, and they are both they are both sarcopenic. So sarcopenic obesity with or without obesity that has been there in the elderly population. Do you recommend?
In sarcopenic patients? Okay, so is there a definite reason why I want to initiate them on GLP-1 receptor analogs?
Yes.
For example, is there a background of cardiovascular history? So is the person going to benefit from use of a GLP-1 receptor analog? So if the answer is yes, I'll still start them on it, and we have to follow them up. We have to train them regarding the resistance exercises. We need to train them regarding the proper nutrition. So that would not be a contraindication for GLP-1 receptor analog, obviously.
In your experience, in which group of the elderly population, above 75, do you use it, the GLP-1 receptor agonist?
Many of my patients are on it.
On above
Many
75?
times I have used it in patients who had a non-fatal stroke to prevent a further episode of stroke. So we have a very robust data in that regard as well. So elderly individuals actually benefit from use of GLP-1 receptor analogs. And now you're going to have all sorts of combinations on board, like say, for example, novel agents like HS235 is one of the agents that is being developed to be used with tirzepatide to prevent muscle loss. So the concerns that we have with the GLP-1 receptor analog regarding the muscle loss are going to be compensated by this agent. So you add one with the other, you get the benefits of the GLP-1 receptor analog, and you prevent the muscle loss as well. All right, thank you.
With this, we come to an end of this wonderful speech. I'd like to invite Dr. Bera to give this memento to his co-chairperson and the speaker.